And good morning. It is now January 9th, my wife's birthday, 2024. We are broadcasting live from Deuk Spine Institute. Surgeries today. We have several surgeries today for you. A cervical, a patient with lumbar, two lumbars. What else?
DPR.
A DPR. But we're doing the DPR in the other room, so we won't broadcast it. So we do have a pretty full schedule. We do take questions. If you have questions during the broadcast, feel free to ask them. Type them up on YouTube, Facebook, or Twitter. Now, our patient comes from from Massachusetts, not Boston, I don't think. And he has had weakness in his right arm. It's getting worse. He can't lift his arm up. He has biceps weakness, deltoid weakness, triceps are starting to get weak. And that's in his right arm. So he's got two herniated discs. He's got an EMG that shows radiculopathy on the right side, polyradiculopathy, which means nerve damage from compression. We're going to go in there and try to remove as much of the material that's compressing the nerves as we can and restore function to his right arm. Doesn't have a lot of neck pain. His pain is more in the muscles, so it's not really discogenic neck pain. It's more radiculopathy that we're here for. Now, he does have, you'll see it on the x-ray, a fusion already, but it wasn't done by a surgeon. It was done by God, and he was born or he developed the fusion years ago. But it's fused his neck in a bad position, kyphotic. And I told him the only way to fix that is to go in and do osteotomies, screws and rods. He doesn't want it. I don't blame him. I wouldn't do it either. But we're going to go in and try to unpinch the nerves at C4-5 and C5-6. He's got disc osteophyte complexes. He wants to do it endoscopically. He doesn't want open surgery. So we're going to give it our best efforts. He's a very big guy. We're also going to be fixing his thumb today, which will be a separate procedure. Shot. All right, 2, 3, 4, 5, 6. All right, shot. AP. First thing I have to do is get my needle into his disc from the front. 2, 3, 4. All right, so I need to get over more. How much relaxation have you given him? Shot?
I just gave him a big dose.
Lateral?
Yeah. Let me check his twitches. Last time it was good.
Yeah, I'm really fighting. Hurry up, Jordan. Shot? We get a little shoulder pull, guys. Shot? And a little neck. Shot? Oh yeah, look at that. 2, 3, 4, 5, 6 shot. Yeah, he told me, Doc, I'm going to be one of the harder cases you do. AP, quick. Quick. Right now, shot. All right, lateral. Need to get a little bit over more, just a little bit more. Shot. That looks pretty good. Shot. All right, let's see where we are with that. AP, my fingers are going to fall off. Shot. What was his twitches? We don't know. All right, that looks really good. Lateral. I'm happy with that. I am in the middle at C5-6. You can count the vertebrae. Go. 2, 3, 4, 5, 6. It's pretty collapsed disc, very degenerated. It doesn't matter. We can get in there and do some good.
Here's some inline for you.
Give me extension.
All right.
Shot.
Nikki,
Huh.
pull in, Nikki. Can you pull for us?
Shot. No, she wasn't pulling. Nikki, it's not time to take a vacation. All right. Shot. So it's hard to get in because he's so calcified. Let's see, 2, 3, 4, 5, 6. Everyone agree we're at 5, 6? That's the level we're doing. One of the two and the one above. So let's get another AP, Coker. Just everybody hang on for a minute. We're right in the front of the disc. He's got a lot of calcification up there. And if I can't penetrate with the angle that I'm at, it's perfect. We're right in the middle. Lateral. If I can't penetrate the disc because I'm sitting against the top of the vertebral body, rather than risk losing that, I'm going to just basically put my dilator down, and then I'll just have to do a discogram. Yeah, shot. So it seems like we're making a little bit of progress. See if I can't wiggle it right in. Again, this is, huh?
There we go.
Shot. This is the harder of the discs. Definitely the harder one to do. So, shot. All right, that's about as much as I can get. I don't think we're going to have a good discogram. Let's go ahead and do a local. At this point, I'm going to numb the skin up. We're going to make our incision, and I'm going to place the guide wire. Now, why do we use local anesthetic when the patient is under general? The answer is because the heart rate and blood pressure can actually fluctuate with pain even when they're asleep. Because you're actually suppressing the cerebral cortex. Hold on. But you're not suppressing the... hold this down.
Yes, sir.
He's got a little fold in his skin, trying to work around. See if I can make that work. You're not suppressing the brainstem. Anesthesia is designed to put certain parts of the brain asleep, but not others. Shot? Yeah, if you put the brainstem to sleep, then the patient is really, really deep. And that takes a lot more anesthetic. All right. So here's what I'm thinking. Did you check his twitches by any chance?
Yeah, I did.
And?
Check 0. Check.
0? That's fine.
Let me check.
No, that's fine.
0.
All right, I'm going to take my needle out but hold my guide wire. So we're right in the front of the disc, but I'm not able to go any further just yet. And that's, I think, because I'm sitting against the end plate of C6. But I'm going to be able to advance it once I get the dilator, and I can redirect and I can go a little bit more superiorly. Hold on. Shot. Here comes the dilator. You see that? Again, we're at C5-6. Everyone agree? And that is one of the discs we're supposed to fix today, or try to fix. Shot? Yeah. All right, there we go. So I'm at the front. Now let's get an x-ray and see exactly where we are on an AP view. Neck looks good. No bleeding, minimal bleeding, like 2 drops, maybe a drop and a half. Shot? All right, we're right in the middle, which is perfect. So far, so good. I'm going to now take the guide wire out, shot, and I'm going to advance the dilator, but I'm going to angle it back a little bit towards the head. Shot? Uh-huh. Interesting. Shot? He's got almost solid bone in here. Looks like he's fusing this disc himself. Interesting. So this disc appears to be fusing itself. Here, take this. Let's see. Yeah. Interesting. Shot. Let me go look at his MRI. MRIs do not tell you when discs fuse themselves unless it's a really, really advanced fusion. An early fusion you can't see on an MRI. Scroll to the right side. Yes, there. Huh. Interesting. So I'm looking at his MRI, and the disc is pretty degenerated, but you can't see that it's fused. How old is that MRI? June. Wow. Yeah, I feel like I'm hitting solid bone. That's not good. Shot. Let's see if this goes any easier. I'll take the mallet. See if I can try to get it redirected. I'm really not hitting it that hard, but it is definitely feels like bone. And I'm not talking about a bone spur. I'm talking about like the whole thing is solid. Shot? Yeah, that came back a millimeter or two. A little inline traction. Shot? Shot? Uh-huh. There we go. Shot? Yeah. So I'm back out. I'm going to try to redirect one more time up. Shot? Let's see. I'm trying to get aimed further up instead of down. Shot? But for some reason his anatomy is forcing me down. I'm going to try again. Inline. Shot? That's a little better. Let's see if we can't make this happen. Now let's try to do a discogram and see if we can get any dye in the disc. Let me pipe clean first. There may be some bone at the end. Notice we haven't lost really any blood, just 2 drops. This is a bloodless surgery. Now this is not a surgery for neck pain. We're not doing this surgery for neck pain like a lot of times we do. Shot? We're doing this because he has radiculopathy. Shot? And the question is it fixable? Shot? All right, so we got a little bit of bone in there. Shot? There we go. Shot? Think we're out. Yeah, we're through. Shot? All right, there's a little bit of dye blush. Shot? There's a little bit. Shot? There's a little tear right there. You guys see that? Jordan? Let's see if we can't get in that. I think we got enough dye. We're not getting a lot, by the way. Normally you'd see a lot of dye. Nice. Very nice. So it looks like we're separating a little bit, which means the joint appears to be still mobile. No, extension. Take your time. We're almost to the back of the disc. Like I said, this disc appears to be auto-fusing, like he did at 6-7. Everything okay? Oh, that's definitely not an easy one. All right, let's see what we can do to help this man. All right, everybody in position? We're going to do a little inline traction. By the way, the whole surgery is done through a small tube. It's an endoscopic channel, or otherwise known as a tubular retractor. Hold on. Shot? Perfect. All right. All right. Don't we want to put the head on first? Yeah. Let's do that. I think that'll make it easier, right? Huh? Go ahead. I need a little bit of shoulder, just a little bit of shoulder pull from Luis, and very minimal from you, and an inline slight extension distraction from you. All right, on the count of 3, everybody ready? Shot. Here we go. Shot. Little more. We're almost there. Very good. Keep it going, guys. We're almost there. That's it. You're doing great. Almost done. Shot. Very good. Almost done. Yeah, I'm hitting that pretty hard. That's about as far in as I can get it. So that might be good enough to get this job done. All right, good job, everybody. That worked very nicely. Thank you. Now let's get in there with the laser and see what we can do. 2, 3, 4, 5, 6. Not an easy one. Thank you. Yeah, he told me before surgery, he said, this is not going to be an easy one, Doc. And it's not. I want you all to notice something else here. Henry, you see this?
Yes, we do.
This is the angle of the tube, okay? Normally, the tube will sit like this. Can you see that?
Yes, we can.
But his is laying down on his chest because the angle of his disc is just that. Everybody's different. That's his personal anatomy, but it makes the surgery very hard to do. It's very hard to get the scope in. He's definitely creating a lot of challenges for us, and he told me he would be. He knows, because he watches a lot of our surgeries, by the way. So he's seen probably at least 15, 20 of these surgeries. All right, where's my pedal, guys? Come on. All right, got it. Here we are at the back of the disc. That's disc osteophyte. Definitely a lot of scar tissue, some bone spurs. Pretty much everything here is bone spur and disc combined. This is not going to be easy. He was right. All right, that's a bone spur right there. Here it comes. Okay, see that? All right. So yeah, you gave him a little more muscle relaxer. That's good. Henry, show our audience the video on how does, this is going to be hard, Luis, so pay attention. I need your help on the chest. His chest is big. How does a herniated disc cause neck pain normally? Now, that's not for him, but this is for other people. All right, we just took off an entire ridge of bone spur right there just before we came back. Maybe you can see it. We had a question while you guys were watching the video. Why does this patient autofuse? And you know, the answer is it's really a combination of things, but genetics definitely has something to do with it. Genes. It's the genes you're born with. They predispose you to things. For example, the next patient, not the next one, sorry, the last patient today, she has Ehlers-Danlos syndrome, okay? And that's a genetic abnormality where her joints are hypermobile. As a result of that, she's got herniations in her neck. Look at that herniation right there. Look at that thing. It won't even float up. It's so calcified and dense. Basically, just a bone spur. So the last patient for today has Ehlers-Danlos syndrome. Very nice woman, but just cursed with bad genes, all right? So We're not fixing her Ehlers-Danlos syndrome with surgery. It's not possible. What we're trying to do is basically get those herniated discs fixed because they're causing her massive pain. It's not the Ehlers-Danlos syndrome that's causing her massive pain. It's her herniated discs and the annular tears, just like everybody else, right? After all, people with connective tissue disorders, they have problems like everybody else has problems, you know? And so everything isn't always related to their connective tissue disorder. They have resistance to local anesthetics, Dr. B tells me.
So the question is, should we use intubation
For her back?
yes?
No.
Okay.
We're not just going to intubate her.
What's that?
We're not just going to intubate her. I want to confirm that it's necessary before we do that.
Okay.
I think we'll be fine. So right here is where the narrowing is. These are all bone spurs. And by the way, he told me in pre-op, he said, you're going to see a lot of bone spurs in there. I said, we're going to do our best. But you do see a lot of bone spurs, no doubt about it. This is all bone spurs. Is there anything that makes these bone spurs grow faster than other people? This is not the Ehlers-Danlos, by the way. This is just a patient who has very much a lot of inflammation. I think he just has a lot of inflammation in his body. And as a result, that creates bone spurs and degenerated discs that fuse themselves. I'm trying to get as much pressure off the nerves as I can. All of this is, the nerve is just deep to this. This is all bone spur. So the more of this I can get out, the better chance his nerve is going to recover. Now he told me, Doc, be so aggressive, be as aggressive as you can. Here's the thing, I can only be as aggressive as his anatomy allows me to be. And what I mean by that is right now, this disc is so collapsed it's pinching my tube. And my tube is not able to move left and right. It's only able to move back and forth, like up at 12 o'clock and then back to the 6 o'clock. So I'm going to try, and I keep going back and forth, and I'm just working it, you know. Let's get the irrigation off this and put it onto this. His chest is so big and the angle is so bad that I'm having to switch the irrigation on the laser tube, the endoscopic tube, just to accommodate. This is all herniation, calcified. It's horrible. This is honestly one of the worst bone spur cases I've ever seen. All right, any other comments?
Yes, we have a couple comments. This both come from Canes25 and Jamie.
Gains 25.
And Jamie from YouTube, both saying happy
Hi, Jamie.
birthday to your wife.
Oh, very sweet of you guys. Thank you so much. Jamie, I don't know if you're a man or a woman, but thank you.
Woman.
I
yes.
shouldn't say you guys, but very sweet of all of you. Thank you.
Canes25 mentioned that happy birthday, Mrs. Spine Whisperer.
Oh, ha ha ha! Spine Whisperer. You saw my cup. My staff bought me that. I think it was you, Nikki. Yeah, Nikki. Nikki got me the Spine Whisperer coffee cup. And thank you. Yeah, Mrs. Spine Whisperer is our CFO. She basically keeps our company going. We need her to make sure all the bills get paid. And yeah, thank you. I really appreciate it. All right, let's switch the irrigation again. So challenging case because the disc is so collapsed and it's basically trying to fuse itself. He already fused the one below. It fused itself. You can see how as I work back and forth with tremendous patience, things are starting to move, right? Like before, everything was just socked in, solid, like a rock. Now we're seeing about a half a degree of movement, not much. Nothing to write home about. This is all scar tissue from the inflammation right there. See that thick stuff? That's all posterior longitudinal ligament, totally scarred up. PLL. This is right where the nerve comes off the spinal cord. This is where it's getting pinched, right in here. And remember, I can only do so much. I can't work a miracle. He does not have OPLL, but he has the closest thing to OPLL without actually having OPLL. Okay, OPLL is far worse and it happens in very young people. Okay, he doesn't, he's not young, but more importantly, he doesn't have OPLL. OPLL is solid calcium, solid bone. Like hard, solid bone. He's got basically very bad bone spurs and very bad inflammation. By the way, he's a regular on our channel. He's always watching, always commenting. That's totally cleaned out. That looks phenomenal to me. I mean, aside from getting in here with a drill, there's no way to do better than that. The laser is pretty darn close to a drill. A drill is better at drilling bone spurs, obviously. Big bone spurs. A laser is good at small and medium sized bone spurs. Thanks. In his case, I could do either. I think this will work for him. I think he'll be happy, but you know, he didn't want a fusion. I don't blame him. Who wants a fusion? Nobody wants to get fused. All right, we'll take questions from our audience, but we're about 3/4 of the way done with this particular disc. This is all calcified. You see the gold color? 100% bone spur. There's like literally, there's no real blue herniation left. It's just horrible. That side looks open. That's his left side. Looks pretty good there. I'm going to go back to the right side. Thank you, Luis. Great job. Not an easy one, huh? No siree. Yep. All right. Any other questions or comments? We're just about done. I've done as much as I can almost here. Go ahead, Henry.
No current questions, but we do have a comment from Canes25 once more on YouTube saying, excuse me, my beautiful wife is scheduled for cervical DLDR, sir, in a few weeks. I know you are going to heal her, and I'm so happy for her that she will suffer no longer. She's everything to me, sir, and I have so much respect for your craft. This is some high-level stuff.
Thank you. Thank you, sir. I appreciate it. We will do our very best for your wife, as we do for all of our patients. And I appreciate your confidence. I'm excited to help her. There's nothing in life I like more than curing pain and suffering in people. So right there, you guys see that's where the nerve is, down in that cave, and we've gotten all the crap off of the top of it. It's pretty much as good as we can do with the laser. So I feel good about it. I'm sticking my endoscope as far down as I can. It literally will not go any further. So I'm maxed out. And he told me to be aggressive. I'm being aggressive. This is all bone spur here. You know, one thing people ask me about, Dr. Deuk, are you going to get all the bone spurs out? The answer is no. We never get all the bone spurs, okay? We're not here to get all the bone spurs. I will not do surgery for all the bone spurs. If somebody tells me, Dr. Deuk, I want you to go get all the bone spurs, I'll say, please go find another surgeon. Or I'll say, hey, I can do that with a drill. All right, but you're going to have a fusion. But if you want what I think is honestly the best, which is get rid of the pressure on the nerve, then you don't want to get rid of all your bone spurs. You can't. No doctor can get rid of all the bone spurs. It's just not humanly possible. All right, I'm going to extend my laser just a tiny bit to see if I can get a little bit more of that junk down there. That to me looks like ligament, foraminal ligament. All right, I can see it clearly. It's right behind the nerve. and it's definitely calcified. I'm pretty happy with that, but that's as much as I can do here for this patient. There's nothing else. That's it. That just opened up his foramen by about, not just that move, but the whole thing. This surgery, we just opened it by probably 70%. That's the foramen, by the way down there. And it's open, okay? So that's the good news. We're done here. And I put a lot of stress on my equipment to do it, by the way. I literally bent my scope. The fiber optic fibers are going to be, compromised. I'm going to have to probably get it repaired. My tube is probably bent. But you know what? It's okay. That's what this equipment's for. It's for fixing human beings. And, sometimes we have to get it out and repair it. But this is putting a lot of strain on the equipment, that's for sure. All right, we're going to now move from this disc to the next one. The next one, I always do the easier disc. I always do the easier disc second. I do the hardest ones first. Why? Because once you start mucking around with the anatomy, you don't want to try to do the harder when the anatomy isn't the easiest to do. Surgeons, when they do surgery, we're changing the anatomy. The soft tissues of the neck, for example. It's riskier the second disc. So if you're going to be riskier, you might as well do it with the easier disc. All right, everything went very well. We opened up his foramen. There's no doubt about it. I got pressure off the nerve. If I had to make a guesstimation, I'd say we got 50% of that narrowing done, fixed. And that's just the best we can do. Look at that foramen now. Look at the foramen at the back of the disc. Jordan, show us the foramen. Right there. Yeah, Jordan's got his arrow right on it. That whitish area, kind of like grayish area, that is the foramen. We've opened that thing up massively. All right. And it's going to compress a little bit when we take the tube out, but definitely better than it was before. Right now, if you look at it, it's probably 300 times bigger than it was before surgery, but when we take the tube out, it's going to collapse down. And if I can get 100% improvement, that would be enough to get rid of his symptoms. Shot? And I think we're going to get 100%. Can you pull pull that up. Yep, up and off. Now pull the tube up and off. Yeah, perfect. So we're taking the tube out, we're leaving the dilator. We're going to do the Deuk slide. This is a maneuver we basically pioneered and invented here at Deuk Spine. And that's where we come out of one disc in the neck and go over to the next disc. Very hard to do. Here we go. We've done it probably about 600 times now. You ready? And here we go. A little inline traction, a little shoulder pull, tiny shot. All right, we're coming out, and we're out right now. I'm out, shot. And I'm going to just get a quick AP. I want to make sure I'm in the middle of the spine. You don't want to get off to the side. If you do, you got to correct it right away. Quickly. All right, we're still in the middle. You see the spinous process. Show them the spinous process, Jordan. See that? Yeah, I want to stay along that track there. Look at this incision, Henry. You see it?
Yes, we do.
Give me a measure. Here we go. Check it out. Folks, that incision, the whole surgery, where other surgeons are splitting your neck open, causing scar tissue, difficulty swallowing, voice changes, bleeding, muscle damage, all that garbage that they do to people with fusions and artificial discs, we're doing it all through a 4mm incision, 4 millimeters, and bloodless. Okay, here we go. Shot. All right, I'm going to start sliding up. Again, shot. It's not easy. Got to monitor where we are. Shot. Everybody ready? We're almost there. I just felt it slip off the edge. Shot. All right, now let's get a quick AP. Make sure we're in the midline. So we're fixing 2 discs today in this patient. Shot. Yes, still midline. Good. You can see the relationship of the tip of the dilator to the spinous process, which is actually in the back of the spine. But you can see it through the spine, and it tells us where the middle is. Shot, that feels good right there. A little more, shot. All right, now, if I'm in the middle, I'm going to be very happy. AP, before you hammer this thing in as a surgeon, you must verify on 2 planes, AP lateral, that you are where you're supposed to be. Otherwise, you can cause serious harm to the patient. All right, perfect. Lateral. I'm moving a little bit over to the right. My right, patient's left. Shot. I think I want to get just a tiny bit further north. Just the tiniest bit further north. Shot. Yeah, there it is. Now, let's get another AP. Every time you make an adjustment, you've got to get an AP and a lateral. Shot. Just for patient safety. Okay? Looks good. I'm anchoring my tip. Is that it? So it slid down. I think we're okay. That's where the body wants us to be. Yeah, we're going to slide right along there. Shot. All right. Let's get an AP. See where we are. That is a bit of an abnormal vertebrae. If you see the end plate right where the dilator is, it's kind of short. Let's go back to a lateral. I haven't made up my mind on this one yet. He's making it very difficult, that's for sure. It's not too bad, actually. Give me a little inline traction. Shot? Yeah. Shot? That felt pretty damn good. See his shot anatomy is, that's pretty good right there. Yeah, I'm not going to get a discogram. Yeah, we're okay right now. We're off the end plate. We're in the middle of the disc. We're right at the back of the tear. I'm going to put my tube in, and we're going to get this done. Okay? One down, one more to go. Shot. All right, we're ready. I need some help from my team. Let me have this. Any more questions?
Yes, this next question comes from Becky on Facebook,
Hi, Becky. Shot.
saying, when you send in an MRI for review, what are the things that you look for to see if you can help someone and do the surgery?
Well, first of all, I don't just look at the MRI, Becky. Great question. Thanks for asking. The most important thing I do is I use the MRI plus the patient's physical exam. That is the key. I've got to see the patient. And I got to look at, hey, where, help me out here, Louise, can you hold that there? I got to look at where shot. Where is the patient having pain? Where are their symptoms? What are their symptoms? So it's really a 3-part thing. It's a history, it's a physical on the Zoom, and it's an MRI review. You understand? So it's not one thing, it's actually 3. If the patient has cancer to your spine, then it's easy. It's a no-brainer. You just look at the MRI, you got cancer. If you have an infection, no-brainer. You got an infection. You can see it on the MRI. If you have a fracture, bad fracture, no problem. See it on the MRI. But guess what? Fractures, tumors, and infections make up less than 1% of back pain. They make up 0.2% of back pain. Think about that. So 99.8% of back pain is made up of things you really cannot use the MRI to make the diagnosis. You use the MRI for some help, but it's really the expertise of the diagnostician, understanding anatomy, understanding the physical exam, the pain generators, and the relative frequency of the pain generators, the location of them. That's how you get a diagnosis. I get people all the time thinking, oh, the MRI reviews just look at pictures or look at a report and you got answers. No, it's not. That is the exact opposite of what we do. Any doctor that just looks at an MRI will never make the diagnosis properly. That's why we have to do a physical exam during the Zoom call. Man. Well, this disc here, I have to say, is not as fused as the last one. It's definitely a little better to work with. Not much. But I can't tell you who this guy's handle is, what his handle is, because that would give him away. But he's a frequent watcher of our surgeries. Is that right, handle, Henry? Did I use the right terminology there?
I think so.
Huh?
I think so. Say it in the sentence one more time.
Huh?
Can you say it in the sentence one more time?
Well, handle is their name, right?
Oh yeah. The YouTube handle,
The
of course.
YouTube
They're
handle.
at. Yes.
Yeah, I don't want to say his because people might recognize it.
No, I
And
understand.
I don't want them to recognize it
Yes.
because patient privacy. So I can't tell you who he is, but he does come on quite a bit. All right, we are on to the second disc. And again, it's not easy because of the angle of the disc. The angle of the disc is making it hard. But this is all herniated disc right here. So kind of a different picture than the last one. The last one was a lot of bone spur, no soft herniation. This is more soft herniation and less bone spur. But there's still a fair amount of bone spur here. Don't worry. For all you bone spur enthusiasts out there. All right. So far, he's doing great. How is he, Doctor? Stable? He's stable. Now, I will say one thing. We are going to fix another body part for him when we're done with the neck. And we're using what's called the Deuk plasma rhizotomy technology. And what it is we have pioneered at Deuk Spine a brand new technology where we're doing a procedure that's been around for a while. It's called a rhizotomy, but we do it a different way than other doctors. We do it in a permanent way. Other doctors do it in a temporary way, so you get temporary relief. We're doing it in a permanent way to get permanent relief. Why? Because it's better for patients to give them a permanent fix rather than a temporary fix where they have to keep coming back and getting treatment. We don't want our patients coming back for more treatment. Simply put, we want to fix them right the first time. Shocking. In this day and age where everything we buy in the store, everything we see is, time limited, and then you have to buy it again, we actually want to provide an enduring result that actually lasts for a lifetime. So, a good result, of course. All right, just about done with this one. Man, it is very inflamed. See all the inflammatory tissue? It's amazing he doesn't have more pain in his neck. He's a pretty tough guy. He is from Boston after all. Any questions?
No current questions, but we do have a comment from Canes25 once more on YouTube.
Of course.
Saying, I'm so happy for him. He's in the right place, that's for sure.
Yeah, thank you so much for your words of positive encouragement. By the way, if you have questions, feel free to ask them. Some of the people in here have been watching our surgeries for a long time, and they actually know quite a bit. But if you're new to the channel, new to the live stream, we're the only spine center in the world that live streams every surgery. By the way, we're just switching the irrigation off. That's why you see us there fiddling around. We're having to move the irrigation to the other side of the endoscope. Here's a big herniation right here. For those of you who are relatively new to our live streams, understand that some of the people here have been around for a while. They've heard me talking for years, and they are actually, pretty knowledgeable in terms of, what causes all the symptoms that we're talking about here and why we do what we do. So I'm happy to answer questions if you have them. I know that it seems like doctors should be focused on surgery. I am, I assure you. but the teaching that goes on here during surgery is the same type of teaching that happens at our universities. Okay, no different. The surgeon has to operate and teach the residents and fellows at the same time. And if they don't teach them, well, then those doctors are going to leave and not be trained properly. And by the way, that happens a lot. This is all scar tissue back here from chronic inflammation. Scar tissue and herniation. A little bit of bone spur there. You see it? All right, I got 8 minutes, doctor. 8 minutes probably. And then we got some other body part we're going to be fixing. So we'll keep them asleep but lighter. That is the foramen right there. So there's a herniation in the foramen. You can see it right there. Here it comes. There it is. Look at that herniation. Just came out of the foramen. Amazing. That was pushing on his nerve. Looks like there's more. Yep, there it is. So he's had severe weakness in his arm. Severe. He can't even lift his arm. He brought videos of himself in the gym trying to lift weights. And he's like trying to get his arm up and he can't get it up. And he showed me the videos and I said, "You must be in pain." He goes, "No, I'm not in pain. I'm just trying to lift my arm and I can't. That's how weak I am." And you just saw the main culprit come out. That was a giant herniation. This is a bone spur I'm shaving down, by the way. He told me before surgery, "Make sure you're aggressive with my bone spurs. Just get them all." I told him I can't get them all. You know that. You watch enough of my surgeries to know that. All right, I'm going to flip again. Let's see if we can keep the irrigation on. Any questions? So far, his surgery is going really well. I know his wife is here. Yeah, I can't. I need to take it off. I got it. I got that. You just move.
Yes, we have a couple of questions.
Sure.
This first one comes from John on YouTube,
Uh-huh.
saying, in the process...
John, huh?
John, yes.
But not Big John.
Not Big John, no. But John did ask, in process of booking my Zoom call, when feet and legs, leg numbness and pain has a positional component, intensity changes with spine position changes, is it safe to assume there is a mechanical cause?
Yes. Yes, that is correct. You are safe to assume there's a mechanical cause. But not just mechanical, inflammatory. Mechanical leading to inflammatory. A lot of people think, oh, there's a mechanical cause, I need a fusion. No, you don't need a fusion. Some doctors trying to sell you on a fusion, don't do it. You don't need it. Come to Deuk Spine and we'll fix you without the fusion. You don't need it. Just get your MRI review done. There's a lot of people who think they can diagnose themselves, or they go out and they get a little bit of information, they see a few doctors, they piece things together, and they think, oh, I know what's best. Unfortunately, I understand your position. You talk to these doctors today about your back pain or neck pain, and they don't know what they're doing, and they don't make you any better. Another herniation just came out. But the truth is you need an expert like Deuk Spine, and there's probably, if I had to say, 5 people in the world, and only one of them is in the United States, that's me, that can make the right diagnosis. But I'm teaching my doctors to do the same, and they're getting pretty good at it. So the problem is you go anywhere else, and the doctors don't know what's causing your symptoms. So what do? They guess. They give you partial truths, half-truths, and they do treatments that don't work because of it. I'm telling you, so many people out there go out and get treatment that doesn't work. And don't be a victim of treatment that doesn't work. All right, I need some help. We're almost done. I got to get to that foramen a little more. There. It's so hard because his chest is bulging out, and it's pushing on my endoscope, and I'm fighting it. Huh? Yeah. Everybody's doing everything. Inline traction from the anesthesiologist. Luis is doing his best. I'm doing my best. We're just trying to get this thing aimed properly. All right, any other questions? Because we're almost done, and we're going to end the broadcast.
Yes, this next question comes from Ron.
1 minute, yeah. Well, but remember, we got the other thing to do. Yes, Rob?
Ram asked, does the laser vaporize extruded disc material, and is that why you don't need to use the grabber tool?
Yes. Yes, the laser vaporizes the extruded disc material and the bone spurs. And that's why we don't need to use the grabber, because all the pieces that are coming out are small enough that they are floating out through the tube that we have. Done. Whew. Done. I don't see any more herniation. Here, laser here. All done. That was a beast. You guys see how this is just pushed up against his chest. So here we go. Irrigation. Not easy. Now, when you get a little bit of bleeding like this, it's normal. That's because we were shaving bone spurs down. When you're removing disc herniations, you don't get much bleeding because the discs don't have much blood at all. But bone has blood. And when you start shaving down bone spurs, you're going to get a little bit of bleeding. Now, that said, it's negligible. There's more blood when you have a tooth extracted than what you're seeing here. This is like so little. So there's really less than 1 milliliter or 1 cc of blood loss with these types of surgeries. All right, we're going to take this tube out in a minute, and you guys will see that there's a tiny little incision. So we probably lost 3 cc's. All right, keep everything sterile because we have the DPR to do. No, we don't need any of this junk for the DPR. All right, questions for me? Because we're pretty much done with his 2 discs, the DLDR. Next, we're going to be doing a DPR, and we're not broadcasting that. Any other questions?
No current questions. We do have a comment from Samir on YouTube saying, coming to you soon, doctor. Can't wait to get fixed.
Happy New Year, Samir. Hopefully it'll be a good year for you and your family. All right, let's get a little bit of benzoin. I'm going to put a steri-strip. We'll do a little pressure dressing, and we'll move on to the next phase. Thanks for joining us, Henry. If you want to share one of our testimonial videos, that would be very nice. I'm Dr. Deuk Machen, CEO and founder of Deuk Spine Institute, Deuk Joint Institute. I'm here with our patient from
Louisiana.
That's right. I had to have him say it. He sounds better when he says it. Why did you come all the way to Florida to the Deuk Spine Institute?
Well, about 3 months ago, I was scheduled for a cervical disc fusion in Shreveport, Louisiana. Had done all the pre-op stuff, was scheduled within 2 weeks to do the surgery, got to work and started doing some research. The more I read about what they were going to do with the fusion, people having trouble with it down the road, above and below the fusion, decided there had to be a better option. So that's when I found Dr. Deuk and his team and started watching some of his videos. Pretty impressive.
And you're a YouTube guy, you were
Yes,
telling
sir.
me, so you found us on YouTube, and what did you think?
Well, our first impression was any doctor that will put his livelihood live on YouTube, showing all of his surgeries, putting it out there, believes in what he's doing. That's not many doctors would do that.
Not just because of that, but because, afraid of complications, which, praise God, we haven't had a complication. We've been doing it now for 17 years. I want people to know there's a safer, better way to take care of their problem other than metal, fusion, stimulators. That's really the message there. You got that message loud and clear.
I did. My surgery was less than 24 hours ago. So far, the tingling, numbing going down my arm is non-existent. It's went away where it was there constantly all the time before. So hopefully this continues on.
Oh, it's gonna continue on. Our results are permanent with the laser surgery.
Yep.
And you can see your tiny little incision right there. It's a 4 millimeter. You can see we went in with a little tube into your disc. I was able to get both discs fixed. You had a lot of herniations in there. Something a lot of people don't understand. They think that a herniation is one piece, but it's about 30 pieces on average. And you had about 30 pieces in each of your discs.
Yeah.
They were hard to get to, but we got it done. And I was very happy with the end results. We got all the pressure off the nerves, and we fixed the tear in the back of the disc. Less than 24 hours, here you are. You're doing fantastic. Now, what did your wife think about you coming down here to Florida? Was she supportive?
She was. This problem had been going on for many years. Started out on my right side years ago and had some stuff fixing that, but she knew the problem I was having. I'm very active. I'm a scuba diver, a motocross racer, do a lot of active sports, and she said, we've got to get this fixed. I'm too active still to actually quit all this. I don't want to quit, so this fusion just seemed like it was going to limit my options on doing things. So that's why we come down here. She was very supportive, and we decided to sign up and come on down.
What do you have to say to your insurance company? What do you want them to do?
I sure hope they pay, because I know they would have paid on the fusion deal, but why they would not pay on this, I don't know why, because results are immediate.
And no narcotics?
No, haven't taken a pain pill, haven't taken anything, nothing. Slept like a baby last night.
That's right. And after fusions, a lot of patients end up in pain management. They're getting shots, they're getting pills.
They can't talk, their esophagus is all tore up from them pushing it out of the way.
That's right.
And I have none of that.
Yeah, our patients don't go to pain management because they don't need it. Anything else you want to say to your fans out there?
If you are considering having some type of neck or back surgery, I think you ought to look at Dr. Deuk and his group, because they got a great facility down here, very accommodating. They'll help you with travel, whatever you need. We flew down Sunday. Today's Wednesday, and we're going to stay till Sunday. Enjoy a little bit of Space Coast. Hopefully get to see a rocket launch here on Friday morning.
That's right. You can see the rocket launches from here and feel them. All right, sir. It's a pleasure.
Thank you, sir.
My pleasure. You have a great day.
Okay.
Let's get you guys out of here. You got better things to do than to sit in a doctor's
Exactly.
office.